Thank you very much for joining us, and it's great to be with you again at TCT Asia Pacific, and a big thank you to the directors for their invitation. We have an amazing session lined up for you, focusing on complex percutaneous coronary intervention. I'm Peter Barlas, cardiologist from Melbourne in Australia, and I'm pleased to be joined by my fellow co-moderator, Mao-Shin Lin. We have an esteemed panel who are also joining us and to go through several very interesting, novel and thought-provoking cases. We have Hanbit Park, we've got Mohammed Petwari, Kaolang Chu and Gakunaka Zawa, who are our panelists, and will obviously be asking some questions and engaging our speakers. So I wanted to pass on to my co-moderator, Mao-Shin, to introduce our first speaker so we can get the session underway. Thank you, Mao-Shin.
Yeah, thank you, Peter. I'm Dr. Mao-Shin Lin from National Taiwan University Hospital. It's my great honor to co-moderate with Peter to this section. And today we have a 6 interesting case. Also, we have 6 cases presented. Now today, now I will introduce the first one. Will be the case. The presenter will be Hei-Yu Zhou from Hong Kong, and he will bring us the title, a case entitled with a case using halfway rotational atherectomy. Dr. Zhu, please.
Okay, so good afternoon, ladies and gentlemen. It is my pleasure to present a case using the technique of halfway rotational atherectomy. So I have no financial disclosure. For our patient, is a 75-year-old lady with history of insulin-dependent type 2 diabetes, hypertension, end-stage renal failure, and paroxysmal atrial fibrillation. She has a history of recurrent ACS, with first PCI done in 2000 with stenting to distal RCA and distal left circumflex. Another episode of non-STEMI in 2017 resulted in further stenting to RCA CTO and proximal left circumflex. This is the coronary angiogram in 2017. We can see that the left main is normal. There's moderate disease in LAD, and left circumflex shows 80% stenosis from proximal to mid-left circ, and distal left circumflex stent is patent. We decided for medical therapy to LAD, and proximal to mid-left circumflex was stented with a 2.2538 DES. For the right side, there is long diffuse disease from proximal to mid-RCA up to 80 to 90% stenosis, and distal RCA CTO with collateral from the left side. PL stent was totally occluded, so RCA CTO was wide with fielded XDR and confirmed true lumen with contralateral injection, then stented with 4 DES. So this is the final angiogram. Fast forward 4 years, the patient experienced recurrence of angina, and an elective PCI was arranged for her. An echocardiogram pre-op was unremarkable except for moderate mitral regurgitation. This is the coronary angiogram in 2021. For the right side, the stents are patent, and there's the old PL total occlusion. And this is the left coronary angiogram. The left main is unremarkable. For the LAD, it was heavily calcified from proximal segment onwards, with osteo to proximal D1 and D2 artery 70% stenosis. Left circumflex stents were patent, and there was minor disease in distal left circumflex. Our plan now is to proceed with PCI to LAD D2 bifurcation. So we chose a 7 French EBU 3.5 guide catheter. We initially wired both LAD and D2 with workhorse wire, but we failed to predilate lesions adequately with small compliant balloons, and were unable to deliver larger non-compliant balloons. So we removed the D2 wire and exchanged the LAD wire for rotor wire. Here we are performing rotor ablation with a 1.5 rotor burr. So the LAD was tortuous and angulated, and so we were unable to cross the lesion with rotor burr. Repeated attempts with rotor ablation was complicated with rotor wire kinking in the distal LAD. So we attempted to remove the wire with gentle traction first, but were unsuccessful. And we tried to remove it using hard tip microcatheters such as Memba and fine cross, but we were unable to deliver the microcatheters to distal LAD. And at the time, we thought that as we had some success delivering small compliant balloons to distal LAD earlier in the procedure, we tried to remove the rotor wire with the use of a 1.5 over-the-wire balloon and finally succeeded. We performed further predilation with a 0.85 10 sapphire balloon and a 2015 NC sapphire balloon afterwards. As you can see, we went much further down with the NC balloon compared to the rotor burr. We then performed shortwave to mid-LAD using a 2.5 shortwave balloon. We wired D2 with a workhorse afterwards and used mini crush technique for the LAD D2 bifurcation. Finally, the D2 was stented with a 2028 Science Sierra, which we then crushed with an NC balloon in LAD. LAD was stented with a 2.533 Science Sierra. We performed port with a 306 NC balloon, and D2 was rewired later. Stent struts were opened with a semi-compliant balloon, and kissing was done with a 2015 NC balloon in D2 and a 2515 NC balloon in LAD. And finally, port was repeated with a 306 NC track. This is our final IVUS through the LAD. So this is the bifurcation. And this is the final angiogram compared to the angiogram at the beginning of the procedure. So we would like to use this case to illustrate the use of halfway rotational atherectomy in heavily calcified disease with tortuous artery. Usually when we do conventional rotational atherectomy, the burr is advanced to the end of a continuous calcified lesion, followed by balloon dilatation. In halfway rotational atherectomy, the burr is advanced, but not beyond any acute bend within the lesion. And for lesions distal to the acute bend, where the burr has not touched, balloon dilatation is used instead. This picture originates from the paper written by Dr. Sakakura. The top three picture illustrates conventional rotational atherectomy, where the burr goes through the entire lesion. Whereas the bottom three picture illustrates the halfway rotational atherectomy, where the burr goes through halfway through the lesion and the rest of the lesion is repaired with balloon dilatation or shortwave. There are many theoretical benefits to using halfway rotational atherectomy as opposed to conventional rotational atherectomy. Rotational atherectomy by itself has risk of perforation and entrapment, or even distal wire kinking as in our case. And its risks are much higher in angulated or tortuous arteries. Using halfway rotational atherectomy instead of pushing the burr through the entire lesion should be safer. A study conducted by Dr. Sakamura and his team in Japan just 2 years ago comparing complication rates between conventional rotational atherectomy group versus halfway rotational atherectomy group showed much reduced risk of vessel perforation in the halfway group. So how about the efficacy of such a method? According to the paper, 90.5% of the time there's successful balloon dilatation following halfway rotational atherectomy. And 7.9% of the time balloon dilatation was unsuccessful, and switching back to conventional rotational atherectomy was required. However, this minor inconvenience may be a small price to pay for the much improved safety outcomes for the patient. So to conclude, the use of halfway rotational atherectomy is safer compared to conventional rotational atherectomy. It is easy to switch back to conventional rotational atherectomy if subsequent balloon dilatation fails. And this method should be considered in patients with tortuous but very calcified lesions. Thank you very much for your kind attention.
Thank you, Dr. Chu, for your nice presentation. The case is open for discussion. Is anyone one of our panelists have a question?
Thank you, Dr. Yu Chu, for your nice, brilliant case. In case of the halfway rotational atherectomy, there may be the chance of minimal stent diameter. What is the comment about the presenter?
Were you asking about the size of the rotor burr?
Yes, in case of the halfway rotational atherectomy, there may be chance of less diameter stent implantation than the conventional atherectomy.
Yes.
What is your comment?
Usually the issue was delivering the rotor burr to more distal part of the vessel. That's according to Dr. Sakamura, the first halfway rotational atherectomy may be able to modify the plaque at the proximal end of the lesion. So you can, other balloons can more easily go down to a more distal part of the lesion. In our case, once we finished halfway rotational atherectomy, we were able to deliver bigger balloons and bigger non-compliant balloons to more distal part of the vessels as well. So I think it can be a safe and useful tool for us to consider in the future.
I think your IVUS actually showed quite good stent apposition on IVUS. So I think it's a very good illustrative case. And it's interesting that sometimes we call rotablation either successful or failed, but here we've got halfway, so that's a great compromise and obviously facilitated a very nice result in the end. So thank you very much, Dr. Chu, for your discussion today.
Thank you.
Malshin, if we move on to the second case.
Okay. Okay, the second case, the second presenter is Dr. Wee Meng Ng from Singapore. And now today he will bring us a case entitled with a hemodynamic assessment to guide revascularization strategy, cardiomyopathy of unclear etiology. Are we too quick to plan ischemia? Dr. Ng, please.
Hello, good evening, everyone. Thank you for tuning in. My presentation is titled Hemodynamic Assessments to Guide Revascularization Strategy in Cardiomyopathy of Unclear Etiology. Are we too quick to blame ischemia? While ischemia is a common cause of left ventricular dysfunction, non-ischemic cardiomyopathy with bystander coronary artery disease is under-recognized. This case demonstrates the importance of being careful when making causative associations between coronary artery disease and left ventricular dysfunction, when often the former is coincidental. Okay, our patient is a 45-year-old Chinese male with a past medical history of hypertension, diabetes, and previous PCI to the left circumflex with a drug-coated balloon in 2015, but he then defaulted follow-up and medication since then. He presented to the cardiology outpatient again in 2021 for exertional dyspnea and worsening effort tolerance over 6 months. Significantly, he also provided a history of heavy alcohol intake for 10 years, quantified to be 41 standard units of alcohol per week. An electrocardiogram demonstrated normal sinus rhythm and changes suggestive of LVH, but no pathological Q waves or STT abnormalities. A transthoracic echocardiogram was performed, which was notable for decreased left ventricular ejection fraction of 35% with global hypokinesis and eccentric LVH. No significant valvular abnormalities were identified. A dipyridinal stress rest myocardial perfusion scan showed fixed medium-sized perfusion defects in the inferior and lateral segments, consistent with partial thickness infarcts, with no superimposed ischemia and moderate retained viability. There was also a small-sized basal to mid-anterior perfusion defect, which was predominantly reversible, consistent with ischemia. Clinical impression at this point was cardiomyopathy of likely ischemic origin, and coronary angiography was subsequently performed for further invasive assessment with a view to revascularization. Here, we can see the coronary angiogram clips for the RCA. Left circumflex, and LAD. The coronary angiogram demonstrated angiographically moderate to severe stenosis with proximal LAD disease, proximal to mid-left circumflex disease, and proximal to mid-right coronary artery disease. We regarded the myocardial perfusion scan findings as somewhat non-diagnostic for the following reasons. Number one, the degree of left ventricular dilatation and dysfunction seemed out of proportion to the extent of the coronary artery disease. And number two, the basal anterior ischemia reported was perhaps artifactual, given the fact that isolated basal ischemia is distinctly unusual without concomitant apical ischemia. And number three, this patient had other features in his history, including a history of alcoholism, which compelled us getting additional evidence before considering revascularization. As such, decision was made to proceed with hemodynamic assessments of all three vessels. IFR was chosen instead of FFR in view of significant transient bradycardia at the start of the procedure, limiting the use of adenosine. Surprisingly, IFR readings of 0.93, 0.97, and 1.01 indicated that these lesions were hemodynamically insignificant. In view of the discordant results between the stress myocardial perfusion scan and invasive hemodynamic assessment findings, a detailed on-table discussion was carried out with the patient. A joint decision was then made for a trial of optimal medical therapy and alcohol abstinence, followed up by re-evaluation with a cardiac magnetic resonance imaging. The repeat cardiac MR was then performed approximately 4 months after OMT was instituted, as well as with strict alcohol abstinence. And it demonstrated recovery of LV dysfunction with no dyskinetic or akinetic segments and no late gate enhancement and an ejection fraction of 60%. So our patient presented with symptoms of exertional dyspnea, echocardiographic evidence of left ventricular dysfunction, non-invasive functional assessment demonstrating ischemia, and coronary angiogram showing angiographically significant moderate to severe multivessel disease. In a large number of practices, this would have led to an ischemic cardiomyopathy diagnosis, followed by surgical or percutaneous revascularization, along with optimal medical therapy. The subsequent improvement in ejection fraction would have erroneously been attributed to revascularization, and it is also likely that this scenario is more frequent than is actually appreciated. In terms of limitation, the congestive heart failure population was poorly represented in the pivotal IFR trials. However, outcomes data appear to support invasive physiology in this cohort, albeit with FFR, and it is likely that hemodynamic assessments with IFR would be similar. We have no conflicts of interest to declare. And this is my last slide. In summary, we present a case of cardiomyopathy that had coincidental coronary artery disease, which was treated medically with normalization of structure and function on cardiac MRI. Clinicians should be cautious in labeling cardiomyopathies as ischemic based on the presence of concomitant coronary artery disease. And in this case, invasive physiology provided us with robust grounds to defer revascularization and optimize his medical therapy.
Yeah, thank you, Dr. Un. Yeah, this case is quite interesting because for me, that for interventional cardiologists, it's very, very difficult to say no when you're doing the coronary angiogram to say no, I will not put a stent in this CAD. So, any question from the panelists that for this interesting case? Yeah, Dr. Nakazawa.
Hi, thank you for your nice presentation. So you chose IFR instead of FFR in this case. I think that's good, but is there any specific reasons for that in this case?
Oh, in this case, the use of IFR instead of FFR was because of the inability to use adenosine because of the bradycardia that was noted at the start of the procedure. We thought about this very hard as well, and we know that there is quite a bit of discordance between IFR and FFR, around 20% according to some studies. But we also do know that this discordance does not translate into negative patient-centered outcomes at the 5-year mark for deferred lesions in a study by Korea's own Dr. Lee Seung-hoon in 2019.
Thank you, Nang, for your nice case. You are unfortunately lucky that without any intervention and CABG, patient is improving and his ejection fraction is up to 60%. But not all the case. Most of the case with ischemic cardiomyopathy with this triple vessel disease, it may need the coronary artery bypass surgery is the best option. Sometimes some patient may be benefited with the PCI. Thank you.
Okay, thank you.
Okay, because his time is limited, so we forward to the next. Peter, do you have question?
I was just going to say, what did you make, Dr. Ng, about the thallium scan? Shall we stop doing thallium scans? No comment about the thallium scan
No.
result?
Yeah, no.
Okay, let's move on.
Okay, next case presented will be the Dr. Kun Wee Kao from the Malaysia. And also he will present the case using a physiological assessment in the patient with a triple vessel disease and CTO. Dr. Ko, please.
Hi, very good afternoon and good evening, everyone. My name is Kun Wee. I'm from Penang General Hospital, Malaysia. It's a great pleasure for me to present a case in this year's TCTAP. The title of our case is Coronary Fissural Assessment in a patient with three-vessel disease and CTO. We have nothing to disclose. So our patient is a 70-year-old lady with underlying comorbid hypertension, diabetes mellitus, and stage renal disease on regular hemodialysis. She presented with frequent episodes of chest pain during hemodialysis and intradialytic hypertension for the past 1 month. So upon arrival to our ward, her vital signs were stable, physical examination was normal. This is her ECG, which showed a sinus rhythm and Q wave at lead 3. Echocardiogram showed an LV ejection fraction of 55%, LA dilated, and hypokinesia at infralateral, infraseptal, and inferior wall. No valvular lesion seen. So the next day, we brought her into the Cath lab. This is the angiogram finding of the left system. So from the AP view and spider view, we can see that there's a significant lesion over the mid-LAD and mid-segment of the left circumflex. There's also a retrograde flow from the LD towards the RCA. This is another view, caudal view and LO cranial view. So from this view, the left main looks smooth. So for the right side, the RCA, there's a proximal RCA CTO with a tapered stump. So in short, this patient is a 70-year-old lady, multiple comorbid hypertension, diabetes mellitus, and stage renal disease on regular dialysis, presented with angina, intradialytic hypotension, and her angiogram showed triple vessel disease with proximal RCA CTO, with the left ventricular ejection fraction 55%. The calculated syntax score 1 was 18 and the syntax score 2 was 49.7. Based on the syntax score, the recommended treatment was CABG. So we stopped the procedure and have a good discussion with the patient regarding option of CABG versus multi-vessel PCI. However, patient refused open heart surgery and opted for multi-vessel PCI. So for PCI strategy for this patient, first of all, we plan to fix the RCA CTO first. Since this is an end-stage renal disease with an upper limb AV fistula, it will need a bilateral femoral access. Then you also need a good stable guiding catheter, both sides. And we also plan to perform a coronary physiology with FFR to the LD and left circumflex prior to PCI and also after the PCI. So this is the FFR value of the LAD. In our center, we use an intracoronary adenosine. So the FFR value for LD was 0.76, which is positive for ischemia. For the left circumflex, surprisingly, the FFR was 0.9, even though angiographically it looked significant. So after that, we perform the CTO intervention for the RCA. We use a 6 French AL unplugged catheter, which shows an antegrade wire escalation technique. We started off with a fielded XT guide wire with a fine cross micro catheter. And we are lucky enough that we're able to cross the CTO segment with a fielded XT guide wire. After crossing the CTO, we did a contralateral contrast injection to confirm that it is in the true lumen, then subsequently exchange the fielded XT wire into our workhorse wire, which is run through for floppy wire. Then we pre-dilated the lesion with a 2O semi-compliant balloon, 3O non-compliance balloon. After we are happy with the pre-dilatation, we finally implanted a 3.5 times 35 mm drug-eluting stents at the CTO segment, then post-dilated with a 3.5 NC balloon. So this is the final result of the CTO. So we're able to achieve a TIMI-3 score, no major dissection. So we accepted the results. We did a FFR to this RCA CTO vessel post PCI, and we get the value of 0.98, which is quite acceptable. Then subsequently, we repeated the FFR over the LAD. This time, the LAD FFR was 0.85. Then the left circumflex FFR was 0.93. So we noticed that the FFR value of the LAD changed from 0.76 to 0.85 after the revascularization of the RCA. This is because the LAD ischemic burden has reduced after the PCI to RCA CTO, because it no longer functions as a donor artery to the RCA territory. Hence, we only plan for medical therapy to the LAD and left circumflex. So the total procedure took 130 minutes, total contrast 200 cc. Patient just ended up with one drug-eluting stents at the RCA. Then we planned for medical therapy to the LAD and left circumflex. She was planned for DAPT for 6 months because she's under the high bleeding risk group. Post-PCI patient was asymptomatic, no more intradialytic hypotension. This is my final slides. So coronary physiology assessment with FFR has simplified our procedure in this patient from an initially triple vessel disease to a single vessel PCI procedure. FFR guided PCI should be considered in patients with multi-vessel disease undergoing PCI because it can help to prevent unnecessary stentings and PCI. As the FAME trial has also showed improved better outcomes with FFR guided PCI compared with angiographic guided PCI. This will be my learning point from our case. With this, I would like to end my presentation. Thank you.
Okay, thank you, Dr. Coy. It's also very interesting for me that the difference of FFR result before and after the CTO PCI. Could you provide any your potential mechanism for why the FFR is different?
Yeah, we think that because before the RCA CTO, the LAD also functioned as a donor artery with a collateral to the RCA territory. So the ischemic burden for the LAD is high before we open up the CTO. Once after we open up the CTO, so there's a reason why the FFR became negative for the LAD.
Yep. Any question from panelists?
Thank you, Kun Kwe, for your case. Donor vessel FFR may be increased after CTO opening due to the narrowing of the collateral circulation. That is, collateral circulation blood flow is decreased. For this treatment, it is improved. And you mentioned, what is your plan for the DAPT about this patient?
For this patient,
platelet therapy.
Yes,
how long you prescribe?
We gave 6 months.
Why it is 6 months?
Oh, because the procedure was like a semi-urgent case. Then a patient also have a high bleeding risk under the high bleeding risk group. That's the reason.
How will you assess this patient having the high bleeding risk?
Oh, the patient has renal disease on regular dialysis, hemoglobin with around 10, just around 10, 11 for her, and 70+ years old.
Any question? Peter, do you have a question?
Can I just ask Dr. Ko, with respect to your procedure for the CTO, it's a very nice result. Up front, you always start off with a 6 French in these cases. I mean, I've typically gone with a slightly more supportive guide. I was interested in that choice of a 6 French.
Yeah, this patient, we use a 6 French catheter. Let's say we need a double stenting, then we need a bigger size, like 7 French.
But you would normally start off up front with a 6 French for all your CTO PCI?
No, depends on the case also. For example, when we think the patient will need a bifurcation stenting, then we may need a bigger height 7 French.
I think you must have exceptional skills to be able to predict which ones are you going to open up with the 6 French guy. That's fantastic. Well done. Great presentation.
Thank you.
Thank you. Nice presentation. In this patient, ECG showed Q-wave and echo showed regional motion at RCA territory. It means the baby RCA CT was related to myocardial infarction. Did you check biopsy tests such as serum SPECT or dopetime stress echo before RCA CT or PCI?
Yeah, before the PCI, we did an echocardiogram.
Biopsy test? Serum SPECT or dopetime stress echo? Biopsy.
It's just a resting echo. It's just a resting echo.
So it's like ECG have Q-wave in the inferior wall?
Yes.
Okay, so it's a scarring or already scarring? Really?
Yeah, we didn't really did a viability scan for the patient.
Okay.
I guess the patient is getting quite symptomatic on dialysis, and I think that's really the major issue here. Sometimes, although we do want robust data to have viability, and this patient is highly symptomatic, so I think you've made an excellent outcome and improved the quality of life for this patient.
Yeah, I agree. Okay, we move to the next one. That will be the case presenter will be the Dmitry from Russia, and he will give you a talk with left main trifurcation stenting. Dr. Dmitry, please.
Hello, everyone. My name is Igor. Let me introduce my report about left main trifurcation stenting. Let's start with main problem. Due to the progress in the production of instruments for PCI, the indication and possibilities of stenting in multivessel disease are expanding. Increasingly, we are choosing a stenting method rather than CABG, even with trifurcation lesions of the left coronary artery. In case of trifurcation lesion of the left main and the impossibility of performing CABG, at the moment, we don't have enough information to choose the best stenting method, especially its effect in the long-term period. According to the PubMed website, several stenting tactics can be distinguished. First, it's double stenting and balloon dilatation of the third artery. For example, stenting LAD and RI and balloon left circumflex. A second method, double stenting without dilatation of the third artery, and triple stenting. We have presented a case of trifurcation stenting of the left main with triple dilatation. Clinical history: patient 66 years old was hospitalized as planned with complaints about chest pain during exercise, but with help for taking nitroglycerin, dyspnea. Increased blood pressure over the years. Diagnosis is a coronary artery disease, stable angina, heart failure, left ventricle chronic aneurysm, hypertension. In test results, ACG is sinus rhythm, heart rate 58 beats per minute, scar change along the lower wall of the left ventricle. Transtoracal echo is ejection fraction 32%, drop of local left ventricle contractility, hardening of the aorta. Holter monitoring is show within normal limits. Perform coronary angiography where trifurcation calcified lesion of the left main was found. Left main 75%, LAD 90%, RI 80%, left circumflex 75-80%. Consultation of cardiac team was held where it was decided to perform CABG, but the patient refused the operation voluntarily. Perform procedure of the radial artery of the 7 French introducer, lower 3 coronary wires in each of the artery. We decide to start with RI since it allowed its diameter. Along the wires, the balloon is 2.5 and 15 millimeters in the LED, and the stent is 2.5 in the RI. A stent was implanted from the orifice of the ramus intermedia into the proximal third with a slight protrusion of the distal edge into the left main. Picture 2. Performed kissing dilatation with prelimination of LED. Picture 3. Next, stent is 2.75 is brought down along the wire in the LED, and the balloon 2.5 in the RI. A stent was implanted from the LED with a small outlet into the left main. Kissing dilation was performed. Picture 4. Next, recording of wires in recrossing of wires in left circumflex and RI, followed by kissing dilatation with two balloons, 2.5 and 15 millimeters. Picture 5. Along the wires, the balloon is 2.5 and 15 millimeters in the RI, and the stent is 2.5 and 18 millimeters in the left circumflex. The stent was implanted from the ostium of the left circumflex. Picture 6. Next, performed kissing dilatation with RI and left circumflex. Picture 7. Stent is 4 and 15 millimeters was implanted from the left main into the RI with low pressure. Picture 8. And next, recrossing of all wires was performed, followed by triple kissing with free balloon, 2.5 and 15 millimeters under high pressure. Picture 9. Control angiography shows a fixed fit of the stents without signs of dissection and obstruction of blood flow. Picture 10. Conclusion. On the PubMed website for similar requests for trifurcation stenting, left main triple stenting, trifurcation stenting, and etc., as an insufficient number of articles on this topic can be noted. And thus, there is not enough information about the correct technique for performing trifurcation stenting. Also, we're using 7 French catheter is quite suitable for this operation. In this case, the ramus intermediate diameter allowed us to implant a stent from the left main into the RI, which in our opinion is the best choice of the subsequent triple kissing technique, because since the cells expand from different sides. The method of trifurcation stenting clearly requires long-term result. Thank you for your attention.
Okay, thank you, Dr. Dimitris. It's quite complicated stenting strategy. I cannot totally figure out what is your step-by-step, but I only have one question. What is your length of DAPT will provide to the patient? 1 year, 2 year, or lifelong? Will you prolong the DAPT dual antiplatelet strategy for this patient in such a complicated stenting strategy in trifurcation?
Since the operation have passed 5 months ago, now patient feels great and is glad that refused CIVG, but consequences are not known to us. In my opinion, the percentage of restenosis is too high, but the patients gave no other choice, and we did PCI, and we are invited him to repeat coronary angiography after 6 months. I think it's indicative.
Peter, will you prolong the
I think, yes,
TCTAP?
I would, Marcin. I would consider long-term. Now, what is long-term, I guess, but I think at least for a couple of years, and maybe if I'm going to stop one of the agents, I will typically stop aspirin and just keep them on some clopidogrel or something like that. Dr. Dimitrov, what about the use of intravascular ultrasound? Is that something that you have available in your cath lab?
We didn't use IVUS. At that time, we didn't have sensors.
Yes.
But we plan to do it maybe next hospitalization, maybe.
Thank you, Igor Dimitri, for your excellent case. In the left main, how long the stent part is in the left main, and final port is done in the left main, and which balloon is used. How many length of the stent in the left main, and final port can you done?
I think is just the how long is your stent in the left main? How long?
On left main.
Stent length in the left main, yes.
Left main, 18 millimeters. 18 maybe, yes.
And did you use a small balloon to expand the proximal segment, a pot?
Yes, of course.
Yeah. What size balloon?
4.5 balloon.
That's okay. You did exceptionally well, considering just speaking to us, and well done. Congratulations.
Yep.
Thank you.
Okay, we'll move to the next one. Will be Dr. Naoki Hayakawa. I'm surprised that it's a case of a PAOD, not a PCI. So it's using it's very long in the title. So I think
yes.
Please, Dr. Hayakawa. Please.
Yes, thank you very much, and good afternoon, everyone. And thank you very much for participating in this wonderful meeting. And my name is Naoki Hayakawa from Asahi General Hospital, Chiba, Japan. And my presentation is about the endovascular treatment. I'm sorry, but not PCI. But I want to talk about feasibility of new novel IVUS guided wiring technique for the CTO lesion. And this is COI slide. The initial success for rate for the FP femoral property long CTR has become very high because various techniques. However, it is extremely difficult to perform the retrograde approach in cases where there is no site for this puncture or the in runoff cases. So this is my case, the 76-year-old female with diabetes mellitus present with less pain and cyanosis of the both lower limbs, and her BMI was over 35, and the ambulatory status was mainly wheelchair. The CT showed the total occlusion of from the SFA just proximal right side from to the popliteal artery and below the knee arteries. The CT length was too long, and there were several calcifications. And there are many problems, and the obesity and the femoral bifurcation was very high takeoff, and the contracture of the knee joint, and extremely long CT with a calcification without runoff vessels. Very tough case. So at first, we performed the contralateral plausible approach, and we dilated the right EIA stenosis with a 7mm balloon, and the guiding cyst was advanced like this. So next, this is control angiography, shows the total occlusion from SFA just proximal to the below the knee arteries. The dorsal pedis artery was barely imaged, but the main trunk of tibial perineal was not imaged at all, and many collateral channels were observed, as you can see. So we advanced 10-gram intermediate 14-inch guide wire with a microcatheter at first. However, the guide wire could not pass, so we went until new IVUS was inserted at the proximal popliteal artery. Unfortunately, it was suboptimal from SFA mid, so IVUS guided parallel wiring was started with using 40-gram hard wire. The red arrow shows the observation from first guide wire with IVUS, and the blue arrow shows the interplaque tracking by second guide wire, the parallel wiring. Like this, and the IVUS transducer and interplaque, we can find clearly. So next, we advance guide wire into the intraplaque loop with IVUS guidance, and could reach the distal popliteal artery. However, the total occlusion continued to the below the knee arteries. So we again performed the IVUS guided parallel wiring from the distal popliteal artery to the peroneal artery. And we manipulated second guide wire, the intermediate guide wire, into the intraplaque route with IVUS guidance like this. This is the TPT to peroneal artery, and this is a proximal peroneal artery, and this is a distal peroneal artery, the parallel wiring. By repeating these steps and on IVUS guided parallel wiring several times, and we finally succeeded in passing the guide wire through the distal two lumen of the peroneal artery, and the tip injection confirmed the distal two lumen of the peroneal artery was connected to the dorsal pedis artery via the collateral tract. So after the balloon dilation, the one epic stent for the iliac and the 4 alluvial drug-eluting stent for popliteal to SFA, and one Ranger drug-coated balloon for the popliteal artery to the TPT, and finally the 3 mm balloon dilation for the peroneal artery. This is a fine angiography. It was the good expansion and sufficient blood flow, antegrade flow. We can confirm. And we could get one straight line from the TPT to peroneal artery, and below the ankle vessels and all of the CTO vessels were dilated from the two lumen, and indicating the emergence of the various branches. And this improves the runoff vessels and improves the antegrade blood flow. And the postoperative ABA improved to 0.09, and a good clinical course has been obtained. So the anti-diabolal is a new IVUS, specifically and developed for the coronary CTO intervention, and with a small profile, asymmetrical structure, and a durable hydrophilic coating, and high resolution imaging. So we previously reported the feasibility of EVT for FPCTO using the anti-all IVUS guided approach like this. And we report how to reflect the IVUS finding to angiography in this report. And in this case, we apply this technique to the below the knee CTO region, and we describe this novel technique as an excavator technique. It is a technique that uses excellent crossability and good image resolution of the anterior IVUS to pass the guide wire in the antegrade fashion, while repeating IVUS guided parallel wiring distal to the BTK. And I think that we can apply this technique for the coronary CTO intervention. So this is my conclusion, that we experienced a very tough case in which a new IVUS was used to pass the all two lumen antegradely, and the revascularization was successful, and we named this technique as an excavator technique. And this technique can be one of the methods to overcome the poor run of cases. So thank you so much.
I'm not quite familiar for the POD PTI, so I think maybe someone can help me to provide some comment to this case. Yep. Any panelists or Peter, do you have any question or comment on this case?
Thank you, Dr. Naoki Hawakawa.
Yes.
What is the advantage of using the AO IVUS than other IVUS technique? What is your specialties here?
The previous IVUS cannot pass the below the knee region. So this IVUS can the very, very closable catheter with durable coating. So using this IVUS, we can perform in these type of repeatable IVUS guided parallel wiring. So I think this technique utilize a coronary long CTO region with a poor distal vessel, I think.
I'm going to ask Dr. Hawakawa, have you done a similar technique in the coronary as well? I mean, I must congratulate you on the technique. It's very instructional, informative.
Yes, thank you very much. Nice question and important question. I have several cases of this technique for the coronary CTO intervention for the right coronary long CTO. After the bougie by microcatheter, we can advance the IVUS catheter to the distal CTO site. So if we can deploy the IVUS to the distal site, we can perform the IVUS guided parallel wiring technique.
Yeah, Of course, I have seen several masters that doing some pyro technique using IVUS to find out the true lumen. I think still doable in the coronary intervention, but yeah, I think needs some experience. Okay, next we will move to the next one. Will be the Dr. Punish Sandana from India. That's will provide a case entitled with shockwave therapy in the calcified lesion. Dr. Sandana, please.
Yeah, good evening, everyone. Today I'll be presenting a case on shockwave therapy for calcified lesion. I have no actual or potential conflict of interest in relation to this program or presentation. Coming to the clinical summary, the patient was a 79-year-old male, a known case of diabetes, hypertension, presented to us with complaints of chest pain on exertion, that is angina, for 2 to 3 months. On examination, his vitals were stable, and chest and CVS examination was also within normal limits. His ECG showed sinus rhythm with STD changes in the anterior lead, some STD depressions, and echo showed RWMA in the LED territory with EF of around 45%. Now we planned for a coronary angiography. Coronary angiography revealed double vessel disease. The LED was showing densely calcified lesion around 80 to 90% stenosis from proximal to mid LED and 80% lesion in ostial and proximal RCA. The RCA lesion was not that calcified. So a plan was to do PTC stenting to LED using IVL, that is intravascular lithotripsy, and straight away PTC stenting to RCA afterwards. So this was the angiogram. As you can see on the left side, there's a dense calcification present from proximal to LED, causing a lesion of around 80 to 90%, and which is clear in other view also. This is the RCA, tight lesion in the ostial RCA and mid RCA, which doesn't seem to be that calcified. In view of severe dense calcification, we planned for taking this patient for angioplasty to LED using IVL. We did a pre-dilatation with 2.5 NC balloon to prepare the bed for IVL. And we took a 2.5 by 12 millimeter IVL balloon for giving the lithotripsy across the lesion to produce microfractures. We give 80 pulses. All 80 pulses were given starting from mid. Then we proceed antegradely to proximal LED, and 80 pulses were given. And after that, IVL using giving by 80 pulses, we straight away took stent. And these are the different views in which we placed the stent. Lesion was post dilated with NC balloon. The stent which we took was 2.75 by 38 millimeter DES. And this was the final angiographic result. So to conclude, numerous surgical techniques have been used to treat calcified coronary lesions, which includes non-compliant high-pressure balloons, excimer lasers, rotational atherectomy device, orbital atherectomy devices, cutting or scoring balloons. These devices have been more significant number of procedural complications like distal embolization, perforations, and dissections, and depend upon the tissue compression and tissue debulking. Furthermore, the success rate decreases with the presence of thick or deep calcification, as in this case, and besides, induced tissue injury may hasten the restenosis and uncontrolled neointimal growth. Shockwave lithotripsy, it's a new technique. It's an ideal and efficient method to microfracture concentric calcium, that is deep calcium, and acoustic pressure waves. The mechanism is that acoustic pressure waves travels through tissues with an effective pressure of around 50 atm and fractures both deep and superficial calcium. And it provides injury-free acute gain to the vessel in lesser time. And there are lesser chances of dissection and perforation.
Yeah, thank you, Dr. Sandana, for the presentation. The shockwave balloon not yet available in my country, so I think I have no further comment. But I have a question for you, is that because we have several tools to overcome the calcified lesion, so like rotablation. So what kind of anatomy that you will first choose the shockwave as a first tool, or what kind of lesion that you will choose rotablation first?
So as in this patient, as lesion seems to be a crossable with a normal balloon, so that's why I choose for this IVL, because if lesion seems to be very, very tight, a non-crossable lesion, then a rotablation is a first choice. And in this, although there was no imaging technique available to us on that day in a hospital, it looks like that calcium is very deep. Looks like it was a diffuse calcification. So these 2 pointers make me choose IVL as the first therapy for this patient.
which imaging technique used for assessment of this calcification? And
So we can use
in this case, what about the calcification?
So that's what I'm saying. On that day, we didn't had IVUS or OCT available in-house. So we didn't have that imaging facility with us. Otherwise, OCT or IVUS, we can use any of the techniques so that it can tell us about the arc of the calcification, the depth of the calcification, and the length of the calcification. Then we'll be more wiser to choose which techniques to be used first.
You use which technique, and what about the calcification of this lesion? It is superficial or deep, or it is transluminal, or it is circumferential?
Because we had just conventional angiography available with us that day, and lesions on angiography looks to be a crossable lesion, so that's why we straight away went with this IVL. So
IVL, it is costly than the rotablator, but
definitely
without any imaging technique, this costly procedure we can prepare for the patient.
Yeah, definitely that is a wiser option. There's no doubt about it. And it was my first case with IVL, sir.
Wow.
Yeah, actually, I was. My question was the same. If you have IVUS or OCT, how do you choose this device instead of rotablator? Maybe you'd prefer this balloon when the lesion has a deeper calcification rather than superficial. And so superficial calcification, will give you a hard time to cross it. So maybe this balloon is not useful in that case, so that the orbital OAS or rotablator is feasible in such.
Yeah. Yes.
And Nakazawa, can I ask you, what choice of imaging would you use in calcified lesions to assess the extent? Is it IVUS, OCT? Which one?
That's a very good question. Lately in Japan, OCT is preferred in the calcified lesion because you can assess depth of the calcification. So that's a big advantage.
Peter, do you have a shockwave balloon in Australia?
Very limited availability at the moment in select labs. So we've got to order it. It is very costly. The hospitals don't like reimbursing or paying for it. So it is challenging to use at this point in time. We've only done, 5 cases or so. So very limited.
What is the price comparing the shockwave balloon and the rotablator?
Well, it's almost double for, say, a rotablator. So almost double for us, yeah.
Yeah, similar in India also, sir. The cost of IVL is just double of rotablation, sir.
But it has a great advantage. That less chance of perforation, but more entrapment and less chance of slow flow than the IVL.
And it's a relatively simple procedure, sir. In comparison to rotablation, has a definite learning curve. There's no doubt about. Although we people out here in hospital use both the methods.
Less learning curve, so short learning curve.
Yes, sir.
So we'll have all our 6 case, interesting case that very thankful our panelists and moderators for discussion. Peter, please help us to closing the session.
Yes, thank you, Marshin. And what a wonderful session we've had. We've had a lot of ranging experts from around the globe and the region looking at, complex coronary intervention, peripheral interventions. And I feel we've really been very much blessed to listen to some new techniques, some novel techniques, and to get a feel of what's going on around our region. So thank you to all our speakers. You've done a wonderful job. Thank you to our panelists for the engaging discussion. And we hope you continue to enjoy the meeting ahead. Thanks very much.
Yeah, thank you, sir.
Thank you. Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.